Hi, this is Yvonne Cruz's um, neonatal assessment video for third semester. I apologize, I do not have a baby doll. I only have a teddy bear. And it's not even mine, it's my sister's. So without further ado, I want to make sure that when I'm assessing baby, I get a full health history from mom, if mom is available, or any parent that is available. For the example of this patient that I'm using today, baby was carried full term to 40 weeks. There was a vaginal birth. There were no complications. Mom delivered fine. Mom did not have an episiotomy. Baby was born with stable vital signs. All that good stuff. I want to make sure that, baby hasn't been diagnosed with any congenital defects. And that mom's pregnancy was good. She didn't have any, preeclampsia, eclampsia, and she didn't have any other complications when baby was coming into the world. So, prior to this, I want to make sure that I am walking into the room, I'm explaining who I am, I'm providing privacy for the parents, I am doing vital signs. The vital signs for this patient today are within normal limits. I have a respiratory rate that's 39. I have a heart rate of 145. I have a temperature of 98, and we're doing that temperature underneath the arm, so an axillary temperature, not a rectal temperature, and baby was 6 pounds 4 ounces. I will try my best to do this assessment while the baby is in the parent's arms, because baby will cry, because I will be annoying them and I will be bothering them. So I want to make sure that baby is as comfortable as I can. Also, it will just kind of help with the parents being able to hold the baby. I can assess different areas. While looking at baby, I want to try to get like an overall view, just observing the baby's skin, the baby's appearance, any asymmetries, any muscle tone, the cry, of course, because baby's going to be crying because I'm annoying them. Is it a strong cry? Is it a weak cry? I want to note any asymmetries. And what I mean by that is like one arm missing, a foot missing, a clubbed foot, a hand that won't go out at all, any inabilities for baby to move properly. I do want to make sure that I'm also looking at the baby's skin. I'm looking at everything as a whole before I start just going in and touching. There can be vernix. If the baby is preterm or the baby's past the due date, normally there's not vernix, and that's that white cheesy stuff on the baby's skin. Most of the time for this baby you would see it because they were born at 40 weeks. I want to make sure I'm checking for amelia. And those are those little white bumps the baby can get on their nose. I want to make sure I'm talking to the parents and letting them know that that's completely normal. That's nothing to worry about. The next thing I want to know, that the parents know about, is lanugo. And that is going to be the little not white hairs, but the little hairs that the babies get. That's completely normal for the baby, for them to have them across their body. I do want to let the parents know about erythema toxicum, which are the red spots or the red acne that the baby can have. I want to explain what that is to the parents, tell them to be aware of it, and just look out for it. If it does come up in my assessment, note it, chart it, and let the provider know. Mongolian spots. I do want to assess the baby's entire skin for Mongolian spots and make sure that when I'm looking at the baby, if there are Mongolian spots or I notice them, I chart them. So that way when they go back to do another assessment, they don't mistake it for a bruise, because Mongolian spots could very likely be mistaken for a bruise and be mistaken for child abuse. I also want to take a note of any petechiae, and those are those little red pin marks that sometimes babies can get just from mom pushing so hard during the delivery. Next, again, I'm going to try to move down from the head to the toes. I might not be able to do this in real life, but for today, I'm going to go to the head, and I want to make sure that I'm looking at any asymmetries with the eyes. I want to assess pearl, not perla, but pearl, because babies don't have any accommodation. So the pupils are round, equal, reactive to light, I want to make sure that if there is strabismus, it is being noted. I want to make sure that the baby's eye color is being noted. If it's, the bluish gray that we would normally see. I want to make sure that the baby's ears are being assessed, checking the baby's ears. If there's vernix on them, that is normal, letting the parents know that that is normal. Making sure that the ears are not lower than the eyes, because that could be a contraindicator for some type of genetic predisposition or condition. I also do want to note the baby's head. If there's modeling, which is of course what allows the baby to be able to be pushed out through the uterus, or through the vagina rather, which is the fontanelles and the sutures of the brain coming over, allowing the baby's head to move through the vagina. I want to note any edema, if there's edema on one side versus the other, if there is a hematoma, cephalohematoma going on. And I want to note the fontanelles. So the posterior fontanelle, that should be in a diamond shape. And so I would flip baby over and look at that and palpate. And then the anterior fontanelle, which is the front, I want to go ahead and make sure that, this posterior fontanelle is in a triangle shape and the anterior fontanelle is in a diamond shape. And I want to palpate that. I do not want to palpate while the baby is screaming their head off, because it might cause some bulging and it could be false positives for the baby. So again, assessing for bruises, edema, any asymmetries, any hematomas, and of course the fontanelles, just to make sure that everything's going okay. Next, I want to move to the eyes, which I kind of already did, making sure I'm checking for strabismus, and I'm checking for pearl. I also want to make sure I'm checking for conjunctivitis. Babies are passing through the vaginal canal and things happen. It's kind of messy, so I want to make sure that there is no redness or irritation around the eyes and that the eyes are within normal limits. Ears, again, I want to make sure that they're symmetrical. There's asymmetry. They're symmetrical. There's no asymmetry. If they have the vernix on it, let the parents know that that's completely normal. Next, I'm going to move to the mouth, and I can put a gloved hand on and put my pinky in there and assess the baby's suck. I could also put my finger on the hard palate on the top to make sure that they don't have a cleft palate. I can also assess for Ebstein's pearls, which are the little calcium deposits in their mouth. If the baby has a cleft palate, I need to let a provider know immediately, because that could be an issue for them long term. Again, assessing suck and swallowing. Making sure that the baby is able to swallow and able to suck, because that's how they will feed. I also want to go ahead and look at the nose, make sure it's painted. So I would check the nose. I can't ask my baby to blow out of each nostril, of course, but I'll check the nose, make sure that they're doing okay. Next, I will assess the chest circumference, and I can also do this along with the head. Do the head and chest circumference and the length with height and weight all at one time. But the chest circumference is going to be from nipple line to the nipple line. Head circumference is going to be across the brow. And then, of course, length is from top of the head to the toes. I would do this with a tape measure. I don't have one with me at my house. Assessing the chest, I also want to make sure that I'm assessing the baby's respiratory rate, and I'm assessing the heart rate at the apical pulse, not a brachial pulse, an apical pulse, and I'm listening for at least a full minute. I will go ahead and I will listen to the baby's lungs. And of course, if they're, freshly newborn, it is normal for them to have a little bit of the crackles, just because they've been sitting in the amniotic fluid. And it is normal for them to have murmurs as well. So I would not be using an adult stethoscope. I would be using a pediatric stethoscope. But that is what I would assess for that. And I'm making sure if I do notice any abnormalities, like chest circumference is bigger than head circumference. Usually head circumference should be larger than chest circumference. And if I do find any abnormal findings there, I need to let a provider know immediately. For the abdomen, I need to make sure I'm taking into account baby's bowel movements, both pee and poop? How often are they wetting their diapers? How often are they being changed? What's their poop been like? Their first poop is meconium, so I need to make sure that I'm noting like the color of their stool. The first stool is black and tarry, but after that, what has their bowel habits been? Are they active? Are they hyperactive? Are they hypoactive? I also want to take into account the baby's umbilical cord area. I want to make sure that if this is an outpatient visit, I'm kind of visualizing the cord healing and eventually getting ready to fall off. And if this is baby fresh out of the womb, I want to make sure that I'm assessing 2 arteries and 1 vein. I want to make sure that that is being assessed and that there's no bleeding around the area, that the, wound is approximated. There's no signs of infection, no redness, irritation, nothing that's traumatic or more traumatic to the area. And I wanted to try to keep that area as clean as possible to allow for proper healing. And again, ask mom, ask dad about voiding habits. How often is baby going to the bathroom? How often are they peeing? How often are they pooping? Are wet diapers few and far between? I want to make sure I'm checking for all of that stuff, because if anything happens, then I would see it in their bowel habits. That's very important. The next I want to do is assess their genitals. So for girls, they may bleed a little bit. And for boys, I want to make sure that if they do have a circumcision, how is it healing? Making sure that I see rugae on the scrotum. When I take the diaper off, of course, I want to make sure that I am assessing for the meatus, and if there is testicular torsion going on, I let a provider know, especially for a boy, because that can have potential impact on their reproductive health later in life. I do want to make sure that I am checking range of motion throughout the entire process. Again, I'm also assessing the cry, but checking the baby's hips. When I lift the legs up, are hips displaced? Are they popping? Are they cracking? Same things with arms. And I want to check the clavicle also, because the birthing process is traumatic to the baby and mom. But I also want to make sure that there's nothing going on here. And if there is something wrong with the hips or something wrong with the clavicle, I need to let a pediatrician know or a provider know immediately, because that could be a contraindicator of something else going on and they need to have other interventions. So making sure range of motion is good. Baby's able to move legs. No hips popping. Everything's asymmetrical, or everything's symmetrical. I can turn baby over. I'm going to assess the spine, making sure that there's no spina bifida. There's no open holes or foramens anywhere. I can assess the baby's bottom, making sure that there's no diaper rash, making sure that the anus is in fact actually working. Spread the cheeks apart, making sure that the baby was clenching, so that way I know that they're going to the bathroom. I'm going to go ahead and make sure that the baby's spine is okay, that it's not curved or anything like that. While I have them turned over, this is a great time to assess the posterior fontanelle. I'm going to flip them back over, and I'll assess refluxes. So I'll assess the hands, make sure that they're able to grab my hand and their little toes, and make sure that their little toes are curling over my fingers. I can assess the fencing reflex, which is where they have one arm out like this, or the other arm out like this. I can assess rooting, where I rub my finger on their cheek, they'll turn that way. And that's for sucking. I've already assessed the sucking reflex, as well as swallow when I put my gloved hand inside of their mouth. And then I can also assess for range of motion of neck. I can assess their spine by, if I put my finger on one side, they'll move to that one side. And that's going to be called the trunk. I can assess Babinski, which is where if I put my hand here and I rub it, the foot will react. And then we can do stepping, where if I hold them like this, they can try to walk, or appear like they're walking. And then I can also assess the startle reflex by when I pick them up, and I like go to put them down, they like jump a little bit. So, that's all I can think about right now. But that would be the, complete assessment. If I'm assessing the back, I always want to make sure that I'm assessing the baby's curvature of the spine. And while I'm back there, assess again for anal patency, making sure the anus actually works. But that is all I can think of at the moment. I would want to answer any of the parents' questions fully and completely. If they have any concerns while I'm going through the assessment, definitely address them. And then, of course, if they need to be put into contact with a provider, if I notice anything, let the parents know. So, and then, of course, wrap baby back up, make them warm, and hand them back to mom and dad, or if they were already still in mom and dad's arms, continue to assess them while they're in mom and dad's arms. But that's it. That's all I can think of. So thank you so much for your time. Thank you, baby. Thank you, parents. And thank you for watching my assessment video.